ICD-11 Obsessive Compulsive and Related Disorders, Implications for Practice and Research by Dr. Shyam Sundar Arumugham. For this session, I would like to introduce the chairperson. First, Dr. Shumon Singh. He is currently an additional professor in Department of Psychiatry, PGIMER. His areas of interest are general adult psychiatry, non-invasive brain stimulation, community psychiatry, and psychodermatology. He has around 120 publications to his credits, and he has won the Bhagwat Award. Our next chairperson is Dr. Krishan Kumar Soni. He is an assistant professor of psychology in PGIMER Chandigarh. His areas of interest are clinical psychology, neuropsychology, and personality. He has around 30 publications to his credits, and he has won around 3 awards. Now I request the chairpersons to introduce the speaker and further conduct the session. Over to you, sir.
Thank you, Sabrish. It's a proud privilege moment when I'm introducing our speaker, Dr. Shyam Sundar Arumugham. He's basically additional professor in psychiatry and he's consultant in OCD clinic in Bangalore. His specialization is in the field of OCD, deep brain stimulation, RTMS, and ECT. He has in his credit around 70 publication and awards and fellowships. So welcome, Dr. Shyam Sundar Arumugham. Now I request Dr. Shumon sir to briefly introduce Sir's topic so that we can continue. Thank you.
Thank you, Sabrish and Dr. Kishan. The topic that Dr. Shyam Sundar will be talking about is ICD-11 Obsessive Compulsive and Related Disorders. What are the implications for practice and research? As we all know, OCD and related disorders have undergone a significant nosological change. So Dr. Shyam Sundar will be talking about it in ICD-11. So Dr. Shyam Sundar, please make a presentation. Dr. Shyam Sundar, are you muted?
Can you hear me?
Yeah, loud and clear. Please
Yeah,
take
thank
it.
you. Thank you, Dr. Shumon and Dr. Soni. So, So I'll be discussing this topic on OCD and related disorders in ICD-11. So this topic was supposed to be presented by Dr. Janardhan Reddy, who's unfortunately not being able to join the session due to some emergency. So he would have been an ideal person to present this because he was in the ICD-11 work group on devising the criteria for this category. But anyway, we have his slides over here and I've borrowed heavily from his slides. So yeah, coming to conflict of interest, I didn't have nothing to discuss, but Dr. Janardhan Reddy was in the ICD-11 work group. So what are the obsessive compulsive related disorders we are talking about? This is a new category that has been included both in DSM-5 and ICD-11. So in DSM-5, these are the 5 main disorders that have been included, which includes OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, and excoriation disorder. ICD has taken a slightly different approach. They've included more disorders than what has been included in DSM-5. So basically, they classify the obsessive compulsive and related disorders into 2 main categories. So basically, all these disorders, the common symptomatology between all these disorders is the presence of repeated thoughts or repeated behaviors. So in ICD-11, they have classified into the OCRDs with predominant cognitive phenomena, that is, which present with predominant repetitive or persistent thoughts, which includes OCD, body dysmorphic disorder, the new category of olfactory reference disorder, and hypochondriasis. And the second category, which is called as motoric OCD, which are the body focused separative behaviors, where people have a tendency to sort of manipulate a particular part of their body. Usually it's the skin or the hair, or it could be which includes the trichotillomania and excoriation disorder. But it also includes other disorders, which are not in the main classification, but it includes other disorders like lip biting, nail biting, and cheek biting also. So there is one more condition, hoarding disorder, which doesn't strictly fall into either the cognitive disorders or the behavioral disorders, which is characterized by persistent accumulation of things which might not be of much use to the person. So these are the main categories that have been included in ICD-11. And tic disorders, it's actually included in the under the neurological disorders in ICD-11. But ICD-11 has the concept of cross-referencing, because tic disorders are commonly seen in patients with OCD. It has been cross-referenced with OCD in the sense that it can be referenced along with OCD, saying that it is a common comorbidity. So what are the major changes that have been made in ICD-11? As I said, the most important change is that the new concept of obsessive compulsive and related disorders have been found, including disorders which new conditions which were not there in ICD-11 at all, and some reshuffling of disorders from other categories. And the other important change is that they have revised the conceptualization, definition, and criteria for many of these disorders. The most important thing being including the insight specifier. I'll be discussing all those things in the subsequent slides. So basically, I will divide the talk into these four major areas. First is, why was OCD reclassified from anxiety disorders to obsessive compulsive related disorder, and rationale for including specific disorders into this group, and what are the clinical relevant changes to the criteria of OCD, and what are the clinical and research implication of this categorization and the revision and criteria. Now, coming to the first topic is OCD and anxiety disorder. Earlier, in both in DSM and DSM-4, ICD-10, OCD was included as an anxiety disorder. So these are the various validators based on which I'll be discussing whether OCD is closer to anxiety disorders or not. So which includes symptom similarity, comorbidity, familiarity and genetic factors, neuronal circuitry, neuropsychological deficits, and treatment response. And of course, clinical utility, which I'll be discussing briefly towards the end. So as I said that earlier, OCD was categorized under anxiety spectrum disorders. The main feature of this anxiety spectrum disorder is the presence of fear and anxiety and presence of somatic symptoms. And in different anxiety disorders, the fear and the anxiety can be precipitated by different triggers. For example, in generalized anxiety disorders, it can be day-to-day hassles. In panic disorder, it could be some somatic sensations. So similarly, it was conceptualized that in OCD is also an anxiety disorder where the anxiety is precipitated by obsessions or unwanted thoughts. And avoidance of the triggers which precipitate anxiety reduces the anxiety. That is common to OCD as well as other anxiety disorders. So there is a lot of similarity between these OCD and anxiety spectrum disorders. But currently, they have formulated the new category of OCRDs, because one major thing that is different in OCD compared to other anxiety spectrum disorders is that presence of repetitive behaviors or compulsions. So this new category of OCRDs have been formulated based on this thing, where all these disorders are characterized by repetitive behaviors, or which is currently known as compulsivity. And OCD, in OCD, anxiety is a secondary phenomenon. The primary pathology is presence of obsessions, which leads to anxiety. And it's usually ego-dystonic compared to other anxiety disorders. And the other major difference is that obsessions are associated with other effects apart from anxiety also. Not all patients report anxiety in response to obsession. Some patients just say they have disgust. And what is currently known as sensory phenomena, which was initially discussed in tic disorder, but many people with OCD also have this phenomena where people do this compulsion just not because to avoid any anxiety or anything untoward from happening, but mainly to have a sensation of completeness or feeling just right. So for example, people arrange things just to feel that they have done things correctly, or just for that sensation, subjective sensation they have. So these are other effects that are associated with OCRDs and OCD. So because of these reasons, it has been suggested that OCD might be a separate category. Now coming to comorbidity profile, major depression is common both in anxiety disorders and OCD, and presence of other anxiety disorders are also common in particular anxiety disorder as well as OCD. So there is definitely an overlap in comorbidity pattern between the two disorders. But the difference is that other obsessive compulsive related disorders are more common in OCD, but they are not seen as common in anxiety disorders. So there is a partial overlap, but there are some specific comorbidity patterns seen in OCD as well. Now, coming to the third part, which is familiarity, I'll discuss briefly about these two studies. The first one is a family history study where they compared a large group of OCD probants with the first-degree relatives with non-OCD probants and first-degree relatives. They found that both anxiety disorders and OCRDs were common. So there seems to be some overlap in genetic makeup as per this study. There is another study. This study, it's a large twin study where they studied only OCRDs. They didn't study anxiety. And they found that two genetic latent factors fit the data very well. One which includes all OCRDs together. There may be a common preponderance which can lead to all obsessive compulsive spectrum disorders. And particularly, there is a particular factor which leads to predisposition to trichotillomania and skin picking disorder. So this study also suggests that there is a strong genetic overlap between OCD and other OCRDs. So OCD has a genetic overlap with both anxiety disorders as well as OCRDs. Now coming to the neuronal circuitry of OCD and anxiety disorders. In anxiety disorder, the commonly discussed neuronal phenomena is amygdala hypersensitivity and insular hypersensitivity. Mainly, this includes the limbic system hyperactivity, especially when anxiety-related cues, either in the form of anxiety-related words or anxiety-related pictures, are shown. So this from limbic hyperactivity is the commonly discussed phenomena in anxiety disorders. But in OCD, various frontostriatal circuits have been found to be involved, which includes multiple different circuits. I'm not going into the details, along with frontal limbic circuits also. So, and these frontal limbic circuits have been frontostriatal circuits have been discussed in the pathophysiology of other OCD spectrum disorders also. So there is a major difference in neurobiology between OCD spectrum disorders and anxiety disorders. And also involvement of reward circuitry, which is commonly reported in OCD, has not been reported in anxiety disorders. So with respect to neuronal circuitry, there is a huge difference between OCD and other anxiety disorders. Coming to neurocognitive deficits, in anxiety disorders, the primary cognitive deficits that have been reported are working memory deficits and attentional bias towards negative emotions. But in OCRDs, various executive functions are the most characteristic cognitive deficits that have been reported, primarily in the form of cognitive flexibility, where the person has difficulty in shifting from one domain to the other, or response inhibition, where the person has difficulty in inhibiting a particular response, and decision making and planning, which are related to executive functions. So here also we see a lot of difference between OCD and anxiety disorders. Now coming to treatment response, if we look into it superficially, both disorders respond to SSRI and CBT. But there is a difference where the dosage of SSRIs required is higher in OCD, as well as people with OCD require a longer time to improve with SSRIs. So there is some difference in that aspect. And CBT is effective in both disorders. Exposure and habituation are common to both conditions, which are the particular CBT techniques. But response prevention is something which is specific to OCD. So there is some difference, but there is a large overlap also. And coming to other medications, tricyclic antidepressants, most tricyclics are effective in anxiety disorders, but only clomipramine, which is particularly serotonergic, is helpful in OCD. Drugs like benzodiazepines, buspirone are helpful in anxiety disorders, but are not been found to be helpful in OCD. So here also there is quite a few differences between OCD and anxiety disorders. So this is to summarize how close is OCD to various other OCRDs versus anxiety disorders in each of these specifiers I discussed about. Phenomenologically, repetitive behaviors, definitely there is an overlap with other OCRDs, but the overlap is partial in anxiety disorders. Comorbidity, there's a strong comorbidity, bidirectional comorbidity with the OCRDs. Here also there's a partial comorbidity. Familiarity also, there is like familial overlap between these both OCRDs and anxiety disorders, but there is a difference in neuronal circuitry and neuropsychology of OCD versus anxiety disorders. And treatment response also, there's only partial overlap. So to summarize, although overlap exists with anxiety disorders, the evidence is stronger for OCRDs. So hence the ICD-11 work group along with DSM-5 work group decided to club all the OCRDs together and place it as a separate category. But they decided to place it immediately after the anxiety disorder classification, so that to emphasize that these two things can be seen commonly together also. And one of the main reasons is the clinical utility. They felt that giving more importance to these disorders might help in screening for these disorders in clinical practice and poster research. Now, coming to the second part, why different OCRDs have been included under this category. So as I said, among the cognitive OCRDs, body dysmorphic disorder in ICD-10, which was included as a type of hypochondriasis, has been given a separate category. And body dysmorphic disorder and olfactory reference syndrome, both are quite similar in phenomenology. Body dysmorphic disorder is a disorder in which a person has increased preoccupation regarding having any bodily or defect in appearance. Where in olfactory reference syndrome, person is preoccupied regarding emanating some foul odor emanating from his body. So the symptoms are quite similar, and the repetitive thoughts and repetitive behaviors, that extreme preoccupation and repeated mirror checking or getting reassurance from others, avoidance, these things are quite similar to OCD. So they felt that these should be included under OCRDs. Hypochondriasis is interesting because in a way, this is also quite similar to the other cognitive OCRDs, because the person has an extensive preoccupation about having a disease. And this is also associated with some repetitive behaviors in the form of repeated investigations, repeated doctor checking, repeated reassurance seeking, and also avoidance. So, and interestingly, the treatment response also is similar, where high dose SSRIs are required and exposure-based treatments have been given. So because of these reasons, hypochondriasis also has been included in ICD-11 under OCRDs, although it has not been included in DSM-5. As I said, body focus and repetitive behaviors, trichotillomania has been shifted from habit and impulse control disorder to OCRDs, because it differs from other impulse control disorders in that it is not an inherently pleasurable activity, and people don't do it for an inherent reward in it, but they have a tendency to do this repetitive behaviors despite the harms associated with it. And there has been both phenomenological and neurobiological similarity in the form of both neurocognitive and neuroimaging studies, and because of which trichotillomania has been included. And exfoliation disorder, it's quite similar, where patient picks the skin instead of the hair. So because of which these two disorders have been included under OCRDs. The last disorder which I'll be which is hoarding disorder, which is a new category which was separated from OCD. A series of research has shown that presence of hoarding symptoms is distinct from other OCD symptoms in many ways, in that it has a different neurocognitive profile, they have a different family history, they have also a distinct treatment response. So it was felt that they don't respond to the other standard treatments of OCD like SSRIs or CBT. So it was separated into a separate condition, and it has been included under OCRDs because there is some often there is a comorbidity pattern with OCD. Now coming to the third part, where I'll be discussing about the criteria for OCD. So this is the criteria for OCD. OCD in ICD-11 has characterized the presence of persistent obsessions and or compulsions. Either one of them should be adequate to make a diagnosis. And obsessions have been defined as repeated and persistent thoughts, images, or impulses and urges. So any of these things could be there. This presence of urge is something that is new that has come into the ICD-11, because people felt that impulses can be misunderstood as something like that's seen in impulse control disorder. So they have used the word urges also. So presence of any of these things which are considered, which the person experiences intrusive and unwanted, is defined as obsession. Compulsions are defined as repetitive behaviors. And one important thing is they have included even mental acts. So compulsions could be cognitive phenomena where a person, it's basically a cognitive or mental compulsions, which was not included in ICD-10, has been included in ICD-11. And another important thing is the compulsions are done usually in response to an obsession. So a functional link between obsession and compulsion that has been included specifically in ICD-11, which was not there in ICD-10. So usually it has been mentioned that usually people do the compulsion in response to an obsession, or they also do it in response to other rigid rules or sense of incompleteness. I'll be coming to the other things in the subsequent slides. So basically, presence of obsession or compulsion, and it should be time consuming, and other usual criteria are there to make a diagnosis of OCD. So what has been removed from ICD-10? One important thing is the duration criteria. ICD-10 required a minimum of 2 weeks to make a diagnosis of OCD, which has been removed because there was no evidence to say so. And compulsions were described as stereotyped behaviors in ICD-10. This led to a confusion between stereotypes, especially in autism spectrum disorders, and compulsions. So because of which this particular word stereotype behavior has been removed. And the most important thing is it was mentioned in ICD-10 that at least one thought or act should be resisted successfully. So in plain words, insight should be intact at least for one obsession or compulsion. But ICD-11 has removed that, saying that people with OCD can have a range of insight from good insight to absent insight. Another major important aspect is the removal of hierarchical approach to diagnosis. Earlier, as per ICD-10, you can't make a diagnosis of OCD if a person has a lifetime diagnosis of schizophrenia or tic disorder. And with depression, there are some specific criteria that were given. But now all these things have been removed. So OCD can be diagnosed to be comorbid with these conditions because this is a very common comorbidity seen, and they usually require specific treatment rather than the treatment for the other disorders. And another major thing that has been removed is the subtyping. Earlier, ICD-10 gave the categorization of with predominant obsession or predominant compulsion or mixed OCD. So that category has been removed for two reasons. One is there's nothing called as predominant obsessions, at least according to most experts, because most people at least have some mental compulsions. And the second thing is they don't have any heuristic or clinical value. They respond to treatment in a similar way. So because of which this subtyping was removed. So what has been added? As I said, compulsions as mental acts have been added. The second important thing is mention of sensory phenomena. As I said, OCD is not always done in response to obsessions. Sometimes people do compulsions just to get a subjective sensory feeling, which is known as just right phenomena or sense of completeness or sensory phenomena. So this is something that is an interesting phenomena that has been included in ICD-11. And as I said, compulsion, the functional relationship has been established. Usually people do compulsion in response to obsession, but ICD-11 also mentions there's a possibility of reverse relationship. At least early in the course of illness, some people develop compulsions first and may develop obsessions later. And the most important thing is insight specifier. There are two categories that have been mentioned, either people with good to fair insight or poor to absent insight. This is most important because people even with the delusional beliefs, like if I come into contact with a particular contaminant, I will develop a disease. If the person is completely delusional about it, the person can be diagnosed as OCD alone, and there's no requirement for diagnosis of a comorbid psychotic disorder. And this insight specifier relates not only to OCD, it is also applicable to other cognitive OCRDs, including body dysmorphic disorder, olfactory reference disorder, as well as hypochondriasis. So in all these disorders, people can have delusional beliefs, but they can be they have to be diagnosed only as the OCRD and not as psychotic phenomena. So OCD also, the ICD-11 also discusses a lot of other additional clinical features which are sort of in keeping with the current research that is going on, like various symptom dimensions, as I said, the sensory phenomena, other effects associated, presence of avoidance behavior, obsessive beliefs, like presence of perfectionism, other obsessive beliefs which are sort of used in CBT for OCD, for cognitive researching. So many of these things have been discussed in the ICD-11 criteria, not in the criteria and in the description. So it's sort of up to date with the current research. Now, coming to the last part of my presentation, where we'll be discussing about the clinical research implications of this categorization. The most important thing is that including many of these obsessive compulsive related disorders like body dysmorphic disorder, body focused behaviors, hoarding disorder, they are often underdiagnosed and untreated disorders. By including them under the spectrum, clinicians have an opportunity to screen for these comorbidities, at least in patients who come for treatment for OCD. And the second one, as I said, the presence of absent and poor insight. It can be diagnosed as the primary disorders, and there's no need for an additional diagnosis. This has a strong research and clinical implication because many of these people who are diagnosed with delusional disorders don't respond to antipsychotics. Studies have shown that even people with BDD or OCD with delusional beliefs related to that particular thought don't respond to antipsychotics, but they respond well to SSRIs. So that there's no major treatment difference in people with and without delusional beliefs. So this is a major clinical implications. And by specifying that these people have poor insight, it can help in implementing CBT because new techniques have to be used. Some cognitive restructuring and other techniques can be employed to facilitate insight. So, and as I said, the third important thing is we can diagnose OCD even if the person has comorbid schizophrenia, Tourette syndrome, or mood disorders. This is important because this facilitates identification of OCD in people with these conditions. And most people with these conditions require specific treatment for OCD also. So it facilitates in clinical practice in that area. And also it facilitates research. Why? Because especially schizophrenia, OCD, and bipolar disorder and Tourette syndrome, the comorbidity with OCD is seen is higher than that seen in the general population. So why do some people with these disorders develop OCD? So that is an interesting area to work on. So that is also something this criteria fosters. Coming to research implication, one of the most important things is, like all other things, ICD and DSM groups work together, and there is a convergence in conceptualization of all OCRDs in both categories. So it's a major boost to research because research done in one area, like we're using one criteria, can be applicable to the other criteria also. And this having this subgroup of OCRDs, people, it might facilitate research on the shared and common neurobiological basis of all these conditions. Already there's a lot of studies going on, like it can facilitate endophenotype research, RDoC criteria, research domain criteria. For example, people now talk about the phenomenon of compulsivity that can be governed by the RDoC domains of habit, cognitive control. Already there is some research going, a lot of research going on in this area. So this categorization somehow has sort of fostered research in this particular area. And also many of these ignored categories in spectrum disorders have been given focus in the ICD-11. And yeah, the importance of core incident OCD and how to treat them, that also has been is important. Yeah, and as I said, non-hierarchical diagnosis is an important addition. So to summarize, the most important thing is that a separate creation of OCRDs, including various OCRDs, and it has been moved away from anxiety disorders. Insight qualifier has been provided for all cognitive OCRDs, with including delusional insight. And tic disorder, it's cross-reference with OCD. And there has been major changes to ICD-11 description and guidelines. And DSM and ICD-DSM-5 and ICD-11 descriptions have been kept in unison for uniformity. Thank you.
Thank you, Dr. Arumugham. Now, this is a really very crispy, collaborative, and lucid presentation. We enjoyed that presentation. Now, I request Dr. Shyam sir to take some very interesting questions from the chat box. Dr. Shyam.
Right. Yeah, Dr. Shyam Sundar, thanks a lot. I think you covered the area very well. You talked about the rationale of the changes, the description of the changes, and finally the clinical and research implications. So we have a few questions. I'll take them up. We are running a little short of time, so we'll keep that in mind. So Dr. Basu asked, why is the olfactory reference disorder classified under this OCRD and not a psychotic disorder?
Yes, that's an important question because sometimes these it can be considered a hallucinations because the person might feel that the smell, only the person is able to feel it and not other people. But phenomenologically, the symptoms are quite similar to body dysmorphic disorder and poor insight OCD, where it is characterized by an extreme preoccupation and presence of repetitive behaviors and most of the other symptoms like reassurance seeking and avoidance, which is quite similar. And treatment response also has been similar, where CBT and SSRIs have been found to be helpful, at least in preliminary studies. So because of which it has been recognized.
All right. So we have another question from Kumari Reena. Why are high doses of SSRI required in OCD as compared to anxiety and depressive disorders? I'd like to twist this a little around. I mean, are high doses of SSRI is required across OCRDs?
Yes, sir. So OCRDs, especially in OCD, body dysmorphic disorder, olfactory reference syndrome, and hypochondriasis, they respond to high dose SSRIs. But other OCRDs don't respond to SSRIs at all, including trichotillomania and other conditions.
At least that is one point against this whole validity thing. All right. So, okay, there are a couple of more questions. Where do we place OCD symptoms secondary to use of antipsychotics? Yeah,
there is a category of medication-induced or other, and at least the medication-induced is available in DSM. In ICD-11, it can be placed under other OCD and unspecified OCD. It can be placed under that category.
All right. And what about schizoaffective and OC symptoms in prodrome of psychosis?
Yeah, if I think we have to look at it conceptually. If OC symptoms are present only during the prodrome and it decreases after that, I don't think it requires a specific diagnosis of OCD. But if the OCD symptoms are persistent along with other psychotic symptoms, then maybe it requires a diagnosis of comorbid OCD.
And finally, I don't know if this is relevant to the topic, but what is the best psychosocial intervention for hoarding disorder?
The issue is hoarding disorder is one disorder for which not many effective psychointerventions
nothing seems to work.
But there is some evidence for some CBT.
Right.
But the technique is slightly different compared to other.
Okay, thank you. I think we're done with the questions now. So it's my pleasant duty to thank the speaker, Dr. Shyam Sundar, and also thank my co-chairperson, Dr. Kishan Kumar Soni, and also the organizers for having given us the opportunity to chair this session and, improving the knowledge of the group. Thank you so much.
Thank you. Thank you.